Welcome everyone to Best Breast Health and Menopause. My name is Shirley Weir. I'm the founder of Menopause Chicks, and it is my pleasure to host this meeting in collaboration with PrimeCare Family Health. If you haven't already, please do answer the poll on the screen. It's just one quick question about whether or not you are currently attached to a family physician. If you're a patient of PrimeCare Family Health, that would be amazing to know. Pop that in there and then do find the chat where you can insert any questions throughout our slide presentation, and there will be time for Q&A at the end. I am the founder of Menopause Chicks. I started Menopause Chicks 12 years ago. Next month, I am 57 years old. I reached menopause when I was 49, and you have to know this. I absolutely love this role that I have been able to create for myself. And what is that role? Well, I consider myself a few things. One is I have a certificate in peer counseling. And so I work with members of the Menopause Chicks community to translate quality, evidence-based information into language or words or understanding or comprehension for what that means for you and your health. So I am not a health professional in the certified capacity, but what our goal is tonight is to make sure that you have access to quality information and you are able to better advocate for your own health with more confidence and ease, and maybe even with some script tips if you need to get curious or you want to take this learning tonight and move it towards a conversation at your next health appointment, or better yet, make a health appointment to specifically talk about breast health with your health team. I didn't know what picture to put here, so I did it. I put my own picture up because I thought, hey, we're all friends, and well, it's a pretty great bra, so I'm sharing it. Tonight's goal, look at the right-hand side of the screen. Tonight's goal is to talk about best breast health in the context of menopause and some of the hormone changes that we experience in perimenopause and in postmenopause. So we're going to really cover three topics that come up the most in the Menopause Chicks community as they relate to breast health. One is breast tenderness. Two is questions around hormone therapy as they relate to breast health. And three is dense breasts. I am working on a new project. It's called Speak Menopause, as if menopause is a language or a lingo. And one of the goals, or one of the things that we can do in the Q&A, if you'd like to, is we can work on a script together, not a prescription, but a script, a talking script, words, phrases, a structure that you might be able to take with you to your next health appointment, especially if you have questions about any of our three objectives during tonight. And I have been working on a structure or a system to create these conversations. I would love it if you're willing to try them out with your healthcare provider, and so that we can gather feedback and find out, what it's like. This is not an exercise in manipulation in any way, shape, or form. What this is an exercise to overcome some of the overwhelming statistics that women face in terms of accessing care. And I'll give you an example. About 5 years ago, there was a study here in British Columbia where I live, and it was called the In Her Words study. The results are at inherwords.ca. And what we found is that over half of women leave their health appointments feeling dismissed or disappointed. you might be relating to that statistic tonight. Those numbers are even higher. So more than half, it was 54%. The numbers were even higher for women, Indigenous women, and women of color. And what's really kind of heartbreaking, as we look at these statistics, is that the top two reasons for the doctor's appointments in the first place were menstruation and menopause. And so I am working every day with members of the Menopause Chicks community to try to close that gap. And of course, I don't have influence over your doctor. I don't know how your physician is going to respond, but by you showing up for this session tonight, we actually have the ability to influence each other and positively influence health outcomes by changing or tweaking or shifting how we show up for our next doctor's appointment. So I invite you to work with us on that, because it's a very exciting project going forward. And if we can do anything to close the gap in terms of women accessing the care that they deserve, I'm all here. I'm here for that. Now, I know that there's some familiar names on the list tonight, and so you may have heard this content before, but it might also be beneficial to hear it again. We're going to go really, really quickly. One of the things that I do in the Menopause Chicks community and in a masterclass that I teach is I talk about the roles and responsibilities of our hormones when cycles are regular, so that we can make a better plan for our health when cycles are no longer regular. Now, we are talking about breast health tonight. So we're going to go very, very quickly to what might be the precipitating factor for someone experiencing breast tenderness, especially in perimenopause. So estrogen is the first hormone that we talk about when we talk about roles and responsibilities. And estrogen is the first hormone to be released in the first 2 weeks of our cycle when cycles are regular. Estrogen's job is to develop an egg follicle and send it on its way. And estrogen has hundreds of roles and responsibilities. Developing an egg follicle is one of them. It also works to protect our heart and our brain and our bones, and it's our juicy hormone. So it helps to keep our eyes and our skin and our mouth and our joints and our vaginas moisturized. In the second half of our cycle, along comes progesterone. Progesterone is the perfect dance partner for estrogen. It is calming. It is supportive of our mood, and it's supportive of our sleep, and it regulates our bleeding, and it takes care of the lining of our uterus. Now, I usually talk about other hormones just to make sure that whenever the conversation of menopause comes up, that we are not only talking about sex hormones. And of course, at the top of this other list is cortisol. Cortisol is our stress hormone, and we need cortisol, but we often don't need too much of it, and we don't need too much of it at the wrong time of day. And so cortisol needs to be managed. It needs to be managed through completing the stress cycle with 30 minutes of exercise, daily walks, walking in green space, practicing mindfulness and meditation. Okay, so this is where I wanted to get to, just with that very, very quick snapshot of some of the roles of our hormones when cycles are regular. So on this chart, and of course, this is going to look different for everyone. This is merely a snapshot of what our hormones do from puberty all the way through to the end of life. So in puberty, on the left-hand side of the screen, you can see a little mini roller coaster with estradiol. Estradiol is one of 3 kinds of estrogen that our body makes on its own. And while that little purple line, estradiol, is starting to fluctuate in puberty, preparing our body for our reproductive years, progesterone is starting a fairly steady hill or mountain, if you will. It's a fairly consistent ride up, and then it starts to decline as we get closer to perimenopause. Estradiol stays fairly consistent through our reproductive years. So you can see why the word balance even came into this conversation, although I don't use balance or imbalance because it can become very confusing to explain, and everyone is different. This picture can look different from morning to night, week to week, month to month, year to year, obviously. But now I'll draw your attention to the perimenopause section of the screen, and you can see what happens to the purple line. So estradiol is now doing a roller coaster again, but it can be a fluctuation that is quite wild. Not for everyone. Some people notice nothing during this time, and about 20% of women have their worlds rocked upside down by this fluctuation. And what I want you to focus in on is progesterone has now declined in perimenopause, but with estrogen fluctuating wildly, it is now high or higher than progesterone for the first time since reproductive years. So reproductive years, it was the opposite. Now they have switched places, and that can be what results in, in what we know as symptoms. So symptoms are represented on this chart by the red line and just a steady increase. I'm going to come back to perimenopause in a second, but before we leave this slide, just to show that when we enter post-menopause, after we've reached menopause, which is the end of ovulation, the end of reproduction, and of course, the end of menstruation, both the purple line and the green line, their tails, our ovaries never produce those hormones at the same levels again. Now, what does this mean for the perimenopause experience? Well, another way to explain it, of course, is the roller coaster, but these are some of the common experiences in perimenopause. You'll notice on the list is included breast tenderness. This is how my journey began. When I was 39, I remember being out at an event and my breasts were so sore. And I was actually I knew there was no possibility that I could be pregnant, but you know how your mind kind of plays those tricks on you, like, well, maybe there's a small percentage, but I was convinced that I was not pregnant. But therefore, I was worried and concerned about why I was experiencing such extreme breast tenderness. And then it went away. And I don't think I felt it again for another couple of years. And then when I was 41, again, breast tenderness, along with some other experiences I had, actually led me to my doctor, actually led me to feeling kind of dismissed and disappointed in that conversation, which led me to the creation of Menopause Chicks. But when I look back, and the rearview mirror is often a great teacher for us, I realized that the breast tenderness that I was experiencing was probably related to that decline of progesterone alongside a fluctuation of estrogen. And that is not unlike what happens if you have been pregnant in your lifetime. That feeling of when you're first pregnant, how the hormones are fluctuating and adjusting to the new state in your body, and breast tenderness can also show itself then. I know for other women, it is almost a monthly experience that might coincide with feelings of PMS or just a signal that their period is about to come. So again, really important that we underscore tonight how individual this experience can be. I've also included on this slide some other common experiences associated with those fluctuating and declining hormones in perimenopause. The second objective of tonight's conversation is to unpack and to clarify why hormone therapy is often part of a conversation that is involved with breast health. Now, I don't have the chat open. I'm not going to get you to vote, but I'm just going to assume that many people have heard an inkling, heard a rumor, or maybe are firmly in the camp that hormone therapy is risky when it comes to our breast health. So I want to do my very best tonight to provide you with the clarity. And I also want to recognize that if this is the first time that you are maybe sitting down and really trying to understand this for your health, that you could leave tonight with more questions than answers. But sometimes it's really important for us to at least get a little bit of information, because what that does is it ignites curiosity, and it usually leads to having more education, opening up the pipeline for more information, and really forcing us to be like, okay, what are the questions that I want to ask, and how does that relate to me? Um, I am on hormone therapy. I am happy to share all of my experiences. I'm 57, as I mentioned. I reached menopause when I was 49. I have been taking hormone therapy since I was 48 or 49. And what's really important to underscore here is that it is never my job to tell anyone to take hormone therapy, but it is definitely my job to make sure that we all understand the benefits of hormone therapy, that we all understand how a benefits versus risk assessment would benefit our own health, and to extend an invitation to all of you to get curious, have a curious conversation about the potential benefits to you. And that is part of my invitation tonight. Now, a little bit of a review of what we are referring to when we say hormone therapy, because hormone therapy is an umbrella term that encompasses a number of different treatment options that are available to women and to men. Sorry, just letting somebody else through there. So I use the umbrella analogy, and on the left-hand side of the screen, you will see things like the birth control pill, the hormone-based IUD, the popular brand name is the Mirena. Tamoxifen is actually a treatment for breast cancer that is a form of hormone therapy. And so is insulin, and so is treatment for thyroid. So you can see what I mean about how hormone therapy is a larger concept, even though it most frequently is referred to when we're talking about menopause hormone therapy. In the middle is menopause hormone therapy, or what I talk about most in the menopause chicks community. And that primarily is systemic estrogen, meaning something that we would take that would benefit our whole system, progesterone, also systemic, and testosterone sometimes, even though testosterone therapy is not approved for women in North America. It can be prescribed in cases where it's needed and where a prescriber is comfortable providing it to their patients in an off-label format. And then we have another category of hormone therapy, which includes vaginal estrogen therapy and or DHEA. And so both of those are administered what is referred to as locally or via the vagina. And then on the other, the right-hand side of the umbrella, I also have included that there are approved non-hormone treatments, and those approved non-hormone treatments are for the treatment of vasomotor symptoms or hot flashes and night sweats. But that's all that they are approved for. So they don't have any of the other systemic or vaginal benefits that menopause hormone therapy is approved for. So all of this work and information is coming to you from the North American Menopause Society, which recently renamed themselves as the Menopause Society. You can find the most current position statement on hormone therapy, which includes information about breast cancer risk at menopause.org. And this position statement is the most current. It's from July of 2022. So in my masterclass, I usually talk about hormone therapy for about an hour. So this is a condensed summary, but then we are going to spend a good amount of time on how hormone therapy relates to breast health. So what is hormone therapy approved for? Well, it's approved for three things. It's approved for the treatment of vasomotor symptoms, which are hot flashes and night sweats. It's approved for the prevention of bone loss. And that's very important because women lose approximately 20% of our bone mass in the first 5 years of postmenopause alone. And without treatment, that bone loss continues for the rest of our lives. And hormone therapy is approved for the prevention and treatment of conditions related to our genitourinary health. Now, genitourinary health is also an umbrella term that includes our vulva, our vagina, our urethra, our bladder, and our overall pelvic floor. Hormone therapy is approved for those three things, but it might have additional benefits. So individuals who take hormone therapy might also realize that, well, if they're taking it in perimenopause, they might notice that there's less bleeding or more controlled bleeding. They might notice, individuals who take menopause hormone therapy might notice some sleep benefits. So the reason I'm making that distinction is that this is a therapy protocol that is approved to treat or prevent, in the case of bone health, three specific things, but there might be additional side benefits. What is confusing? Well, lots of things are actually confusing when it comes to hormone therapy. There are a lot of different terms. I've already thrown a couple at you tonight, such as systemic hormone therapy versus vaginal hormone therapy. Another term that often gets cradled in confusion is the term bioidentical versus non-bioidentical. So I'll unpack that for you as quickly as I can. Bioidentical and non-bioidentical refer to the molecular structure of our hormones, of the hormone therapy that we're taking. So bioidentical could, in theory, have been called biosimilar because what it means is that a bioidentical hormone therapy is similar to the hormones that were once made by our ovaries. Non-bioidentical hormone therapy has a molecular structure that's designed to fix a particular problem or challenge. So what we mean by that, and I'll give you a couple of examples I'm sure all of us can relate to. Non-bioidentical hormone therapy examples include the birth control pill and the Mirena IUD. So in both of those treatments or therapies is a progestin, which is a non-bioidentical form of progesterone. Our ovaries never made progestins. It's a non-bioidentical molecular structure designed to prevent a pregnancy. So non-bioidentical doesn't mean bad. It means different. So there are many applications for non-bioidentical hormone therapy, and there are many applications for bioidentical hormone therapy. Bioidentical doesn't mean good, it doesn't mean better, it means the molecular structure is similar to the hormones that our ovaries used to make on their own. When it comes to menopause hormone therapy, most women, most practitioners are choosing bioidentical hormone therapy systemically, which would be estrogen and progesterone, and vaginally. The third bullet point here that usually requires clarification is, when do I start hormone therapy and how long can I take it for? There was an old school of thought prior to this 2022 position statement on hormone therapy that said, take the smallest amount of hormones for the shortest period of time. That is no longer the recommended approach or the approved approach for menopause hormone therapy. And here's why. If you and I were baking a cake and the recipe called for a cup of sugar, and we put in a teaspoon of sugar, we would most likely be disappointed with how that cake turned out. And I use that analogy because the smallest amount for the shortest period of time is not a recommended strategy if you are someone who is A, trying to eliminate symptoms, and B, trying to invest in your future heart, brain, bone, and genitourinary health. So the way to approach hormone therapy, when to start it, is follow the guidelines with your healthcare provider. But remember that they are guidelines. They are like speed limit signs. It's the recommended guideline to begin with or to start with, but it's not a deadline. For example, the North American Menopause Society recommends that we start hormone therapy within 10 years of menopause and or under the age of 60. Still a guideline. If you are 61, it is not too late. It just means that you might have a different type of conversation with your healthcare provider about other health conditions. The biggest one to be concerned about is if you have had a stroke or if you've had blood clots, your prescriber needs to know that, and doesn't still mean that you might not be a candidate for hormone therapy, but you might be monitored differently, or your results might be reviewed more frequently than someone who didn't have that experience. So when to start, the guideline is within 10 years of menopause under the age of 60. How long to stay on hormone therapy, also an area of some confusion because some physicians are translating old misleading information that said you should stop taking hormone therapy by the time you turn 60, or that you should only stay on it for 5 years. Let me be really clear. The 2022 positioning statement on hormone therapy does not recommend a timeline for how long we should stay on hormone therapy. I have been taking it for 8 years. I review it regularly with my physician. If something was to change with my health, that might be an indicator for making some changes to that protocol, but it is very individualized. It must be decided via shared decision-making between you and your healthcare provider. And what is going to go into that decision-making process? Well, A, how do you feel? So are your symptoms being managed by the protocol that you're on? And B, what are your health goals? Are you strength building? How is your nutrition? Those would be two other things that would go into, for example, a bone health strategy. And before you stop hormone therapy, you are going to have to really make sure that you have a bone health and a heart health strategy in place. That was a really quick summary, but I do want to move on to a key part of tonight's conversation, which is understanding true risk and not leveraging all of the benefits that are involved when we have conversations about hormone therapy. So here's the question that you may be asking, or you may already know and have done your own research, but why was breast cancer linked to hormone therapy in the first place? So in the 1990s, there was the proposed very large women's health initiative study. And the original goal of this study was to show or to demonstrate that hormone therapy would have an advantage to preventing heart disease in women. Okay, so notice we're not talking about breast cancer at all. The original intent of the Women's Health Initiative was to show that hormone therapy could demonstrate some benefits to preventing heart disease, which is the #1 premature killer of women in North America. Now, what they wanted to do was recruit, I think it was 30,000, but like tens of thousands of women who were around age 50 or 51, which is the average age of menopause in North America. And they were going to divide the 30,000 women in half and give half of them placebo and half of them hormone therapy and follow them for 30 years. Well, I don't know if you've been involved in many health studies, but imagine being recruited for that study and not knowing whether you were going to get placebo or not. And so, some people would obviously be quite disappointed if they ended up not getting placebo, but the study showed that hormone therapy would have an advantage. And so then their health for 30 years was put at a disadvantage. I mean, it was a very lofty but well-intended study. So what happened? Well, when they couldn't recruit the 30,000 women, there were some compromises made. They went with a much smaller study group, okay? And the folks that they recruited for the study were not 50. Their average age was in the low to mid 60s. So 61, 62, 63. And when they divided the group in half and half got placebo and half got hormone therapy, they started to notice, so now we're like two years in, they started to notice some health conditions popping up. They started to notice a higher rate of heart disease and stroke, and they started to notice a higher incidence rate of breast cancer. And that's what we're going to talk about for this next section is the risks, the true risks of breast cancer need to be understood. But before we go there, when the incidence rates, the higher rates of heart disease and the higher rates of breast cancer started to show themselves, it became very scary for this study to continue. So it was halted early, even though there were still many key learnings that came out of the Women's Health Initiative study, learnings that we still use today in this space. What happened was the information then turned into a PR nightmare. Word got out, headlines love short and snappy bite-sized pieces. And what happened is that they made the inference that hormone therapy causes breast cancer because the study had seen a higher rate, but the higher rate was amongst a group of 60-year-olds, and we didn't know that until much later, or until, you started researching this. And we know in hindsight, remember I said the rearview mirror, that age is actually a risk for breast cancer. So the incidence rate among 60-year-olds is obviously going to be accelerated or increased over the group of 50-year-olds that they originally wanted to study. We have been living with this misinterpretation because once something is on the front page of the New York Times and the front cover of Time magazine, and all doctors everywhere started unprescribing, taking their patients off of hormone therapy, it's really hard to unring a bell. And so this misinterpretation has lingered on, and it's created probably one of the biggest health crises, certainly in women's health, that we will ever experience. But I'm optimistic, and I say just because we got it wrong, we as society got it wrong for the last 22 years, doesn't mean we can't get it right for the next 22 or longer. Oops. So in summary for hormone therapy, and then we'll get into talking about benefits versus risk. Remember I said hormone therapy is approved for 3 things. I often get asked about, well, so what, when it comes to making decisions about hormone therapy, what do I need to know about my heart health, my brain health, my breast health, my bone health, and my vaginal or pelvic health? Well, we may never see a report or a research, another new research paper coming out that says hormone therapy is approved for the prevention of heart disease. 2 reasons for that. We've got a history that's steeped with a lot of negativity, if you will. But the second thing is that heart disease is multifactorial. And so there are many things that can contribute to someone getting heart disease. So I'm not optimistic that I will see this in my lifetime, that hormone therapy gets approved for the prevention of heart disease. However, we know, and the reason why I talk about the roles and responsibilities of our hormones when cycles are regular is we know when cycles are regular that estrogen and progesterone protect our heart and protect our bone and protect our vagina. So it might be that it's an additional one of those side benefits. And I use the word might because there are obviously going to be other factors that contribute to someone getting cardiovascular disease. We haven't yet, in terms of brain health, we haven't yet seen anything that says hormone therapy should be discussed or approved for the prevention of dementia. Although there is a lot more work going into women's brain health. And if you're interested in that, you can follow the work of Dr. Lisa Mosconi. And I think that we will see definitely more develops in both of these areas in the next decade. When it comes to breast, we do not understand the definition of incidence rate versus risk. So that's where we're going next. And then, of course, as I mentioned, for the prevention of bone loss and the prevention and treatment of symptoms related to our genital urinary health, hormone therapy is approved for that. Okay. So let's unpack and talk about risk. This white part of the screen that you're seeing that starts with key points is a direct screenshot from the North American Menopause Society position statement on hormone therapy. And this is what is important to understand. The risk of breast cancer while on hormone therapy is low. Low doesn't mean 0. But there are a few things in life that come with 0 risk attached to it. So while we need to understand risk, we also need to have a conversation with our healthcare provider about benefits versus risk, because the very last thing that we want to do is to have another generation of women fearful of hormone therapy, which I can understand, especially in some family context. I get it. But we don't want a whole generation fearful of hormone therapy and the risk being really low, while they put themselves at greater risk for osteoporosis, or simply they are suffering with symptoms such as vasomotor symptoms, not enjoying quality of life. And maybe, their overall vitality is declining simply because of a very, very small incidence rate or risk. So I'm going to try to unpack some of the math that the North American Menopause Society is giving us. On this screen, they are talking about a rare occurrence, less than 1 additional case per 1,000 of women using hormone therapy and breast cancer showing itself. And for those women, I think it's on maybe on the next screen. Yeah, it's on the next. The risk goes up to 3 in 1,000 for women who stay on hormone therapy for 5 years. Now, this yellow asterisk, super important to hone in on, because when we're talking about breast health, we must understand what the real risks of breast cancer are. The number one risk is having breasts, of course. The number two risk for breast cancer is age. So 1 in 8 of us will get breast cancer if we live to be 85. Sometimes we see 1 in 8 and not everyone explains the age parameters. So for example, if you're watching this tonight and you are under the age of 85, your risk is lower than 1 in 8. The next risk for breast cancer is going to be genetics. And it is not like my mother's sister's daughter's aunt's best friend had breast cancer and therefore I'm scared I might get it too. It is not that. It is a 1-degree relative who has had breast cancer, which does not mean that you will get breast cancer. It means that you are invited to have a genetic conversation with your health team. In some cases, that might even mean being referred to a genetics counselor who can do a bit more of a predictive model for you. But if you have a 1st-degree, 1-degree relative who's had breast cancer, then this is an invitation for you to pay attention to that risk factor and to have it all lined up in a contextual, easy to understand risk assessment lined up with your age and with some of these modifiable factors, which I'm going to go to next. And this is not always an easy conversation to have, but modifiable factors means this is where we are in the driver's seat. This is where we have some level of control as to how we influence our risk for breast cancer with or without the decision making around hormone therapy. And these are the 3 things that fall under the umbrella of modifiable. Alcohol use. It used to be up until January 2023, where even healthcare professionals would say it's okay to have a glass of red wine at night with dinner. If you only have 1 glass, that's 7 per week. The new recommended guideline for alcohol consumption for women is 2 per week. So we can modify our alcohol consumption as a way of potentially lowering our risk for breast cancer. The other 2 modifiable factors are obesity and physical activity. So just to recap, the risk for breast cancer is having breasts, our age. 1 in 8 of us will get breast cancer if we live to be 85. Do we have a 1st-degree relative with breast cancer? If so, we need to talk about our genetic risk with a qualified health professional. And we need to be aware of what we control ourselves, which is the modifiable factors that include alcohol, weight, and physical activity. When we move that into a conversation around hormone therapy, we need to understand that the incidence rate, which is different from risk, is low. It's 1 in 1,000 per 1 in 1,000 women, 1 in 1,000 women per year of hormone therapy use, or 3 additional cases per 1,000 when those women use hormone therapy for 5 years. my brain doesn't really work in terms of what 3 in 1,000 means. What does that mean for me? So if we equate that into a percentage, for example, 3 in 1,000 is 0.3%. So less than 1/3 of 1%. That's how it is translating. But also, this number that we're using is for someone who is using hormone therapy for 5 years. So therefore, she is also 5 years older. And age, of course, is a risk factor for breast cancer. I needed to put this for myself into a different context. I had to ask myself, what is something else that we could compare that to that I do on a regular basis? And so I thought about, well, what is the risk for being killed in a motor vehicle accident? And the chance of being killed in a motor vehicle accident is a 1 in 101. So when I do the percentage on that, that's 0.9%. That is still less, just under 1%, but it's 3 times higher than the incidence rate for someone getting breast cancer while on hormone therapy. Hopefully that lands with you and we can move on to dense breast, but I am happy to, because I know this can be very individual and we all know someone with breast cancer. We all know someone with heart disease too, and more women die every year due to cardiovascular disease than breast cancer. But at the same time, no one wants that as part of their journey. And certainly those of you that have showed up here today who are very proactive with your health, you want the information for yourself. And I know that you also want to be able to articulate and explain it to those people that you love too. So let's make sure that we hop into the Q&A and to make sure that you have the tools or the language that you need to do that. So yeah, the summary is to make sure that you are able to talk about the benefits of hormone therapy versus the real to you risk. So the benefits would be saying goodbye to vasomotor symptoms, preventing bone loss, taking care of your genitourinary health, and then any real to you risk. So that could be cardiovascular risk, it could be blood clot risk, it could be personalized breast cancer risk. It's very individualized. All of your decisions need to be made via shared decision making with your health provider. And finally, on this slide, what I want you to also remember is that it's not enough to be scared of a little risk. For example, that incidence rate of being killed in a motor vehicle accident usually doesn't prevent us from hopping in our car or getting into the back of an Uber. And so the question that we need to be asking is, what is the real risk maybe of not taking hormone therapy, or at least not getting curious? This is a very busy slide, but I did snapshot it. This is from 2023. It is also from the Menopause Society, and this is about non-hormone therapy or non-hormone treatment options. I get asked about this a lot. I understand the mentality or the thought process of someone saying, Shirley, hormone therapy, it sounds like a lot. It sounds confusing. I don't have the bandwidth to think about it. I don't have a family physician right now that I can talk to or that can help me advocate. So what if I just take a non-hormone therapy option? So I wanted to explain that with you tonight. Non-hormone therapy options exist. There are a few that are approved. There are many that are not, and that's what I've highlighted in the yellow. So if you're being exposed to algorithms, marketers, media, who's trying to tell you that all you need to do is avoid spicy foods, for example, to prevent or eliminate vasomotor symptoms, that's not an approved treatment. But the first thing that we need to understand in non-hormone therapy treatments is that hormone therapy is the first line recommended treatment for women in menopause by all the menopause societies around the world, by the Canadian Medical Association. It's where we need to go to first. And for 99% of women, they won't have any contraindications, but there is a small percentage of women who maybe have suffered a stroke or just maybe have something where the benefits don't outweigh the risk. They still are not meant to suffer. They still deserve to feel amazing. And that's why it's good to know that there are non-hormone treatments available, except these non-hormone treatments are for vasomotor symptoms only, and they are not going to prevent bone loss, and they are not going to take care of genitourinary health. Now, that's another great segue or reminder for us that vaginal estrogen or vaginal hormone therapy is safe for everyone to use postmenopause and for the rest of our lives, even breast cancer patients. So if you have had breast cancer and you have decided with your healthcare provider that you're not going to take systemic hormone therapy, you can still take vaginal hormone therapy. I think that's what I was trying to say right there. I want to spend the next 5 minutes talking about breast density. I am not a breast density expert. I do surround myself with many of the experts. And what I do want to stay on top of, which I'm super keen to do for all of the members of the Menopause Chicks community, is all of the changes that are happening at lightning speed in the dense breast community. And there are great advocates for this information at Dense Breast Canada. Now, what is a dense breast? Well, really, it is just it's a measurement of the fibrous tissues versus the fatty tissues that we have in our breast. And what you see on the screen here are 4 categories of measuring that breast density. So A, B, C, and D, D being the extreme dense. Now, why is this information important to know? And I think hopefully everyone on this call is having regular mammograms. Hopefully everyone on this call lives in a province or geographical region where your breast density is being reported to you when you have your mammogram. And depending on your classification or measurement of density, you are then being accelerated into additional screening. Why is all of this important? Well, what we are looking at is the side view of a mammogram and how a cancer can show up on those screenings. So cancer is going to be much easier to identify in a fatty or a non-dense breast. And it gets harder because it's that white dot. It gets harder to identify the cancer as we move across the breast density spectrum. Having dense breasts, and it's going to probably, depending on where you live, being reported to you whether you are a C or a D level, doesn't mean that you have breast cancer, and it doesn't mean that you will get breast cancer, but it does mean that you are at a higher risk because the cancer is harder to detect. So I wanted to make that an important clarification tonight. Other things that we know about breast density as it relates to menopause is that dense breasts can decrease and likely will decrease in postmenopause. And you might even notice that if you are postmenopause yourself and you're going for yearly mammograms, you may have been a D and now you notice that you're a C or a B, or you've just, your doctor has prepared you that dense breast, sorry, I'm starting to get my words all mixed up. I've been talking all day. You started to have a conversation about the potential benefits of hormone therapy with your doctor, you want to include your status of breast density in that conversation. Now, that might mean that you are delaying a decision making about hormone therapy, which may or may not mean that you are suffering. You want to make sure that you're not meant to suffer and that you put that at the top of the list. But that if you do go forward and you and your healthcare provider decide that hormone therapy is something that you want to pursue, that you marry that with your breast health density rating so that maybe there's more screening, maybe there's more frequent reviews and screening for you. And remember, all of this, we are all individuals, and so our health protocols should align with that as well. Okay. I'm now back to the script part, but I think I'll just jump into the questions to make sure that I can answer any that you might have. And if you want, we can come back to this. This is an example of a script. And one of the examples I thought that we could work through tonight would be perhaps someone who has had breast cancer and is suffering with vulva and vaginal dryness, vaginal atrophy, reoccurring UTIs. They've been told they can't take hormone therapy, but it was never explained to them that they could, in fact, take or qualify for vaginal hormone therapy, and even if they are a breast cancer survivor. So that was the example that I'm happy to work through. Maybe we have someone in the queue, but I'm going to close this down and open up the chat so that I can start talking to you. Thank you so much for listening. Okay. Jennifer, can you, oh, maybe you can't. I was just going to see if you could check and make sure that everyone, and just a reminder to answer the poll too for Prime Care Family Health. Okay. Somebody didn't see the poll. Okay. Huh. Oh, okay. Yeah. Prime Care Family Health wants me to mention that we are working on a series for of Prime Care webinars for 2025. We haven't published the whole menu yet, but I just wanted to remind you of that. Thank you for coming out. And if you have enjoyed this content and you want to continue to keep your name at the top of your list for 2025, that there's more to come. Okay, somebody is having glitches. I'm not sure if that's with the poll or just with their internet connection. Do symptoms return once you stop hormone therapy? That's a great question, and I get it a lot, and I understand why there is questions and even some confusion around that. So symptoms will often refer, when we say symptoms or when consumers say symptoms, it often refers to vasomotor symptoms, i.e. hot flashes and night sweats. And then the night sweats sometimes affect our quality of sleep and so on. When you stop hormone therapy, it is really, again, another individual experience. Some women stop and notice nothing, no changes whatsoever. But you still would have to make sure that you have a solid bone health plan in place and a solid cardiovascular health plan in place. And when it comes to your vaginal health, I would recommend that you either continue moisturizing your vulva and vagina and doing whatever you can to prevent UTIs. So the approved prevention strategy for reoccurring UTIs in postmenopause by the Canadian Urological Association is vaginal estrogen. So even if you were to decide to come off of systemic estrogen and progesterone, I would continue with a form of vaginal hormone therapy. Whether or not your vasomotor symptoms come back, I'm sorry to say, is going to be a very individual experience. It's going to depend on a whole host of things. And that might be part of your decision-making factor with your healthcare provider too. Okay, technical issues. Okay, the webinar is being recorded. Yes, it is. And we'll be happy to share that afterwards. Next question. Are there conditions or medications that would preclude you from being able to take hormone therapy? Yes. Again, it's going to be very individual. The example that I use the most is if you have had a stroke or if you have a history of blood clots or a blood clotting disorder, that might be something that would go in the risk column when you and your healthcare provider are weighing the pros and cons. Again, that doesn't apply to vaginal estrogen. Other conditions that might exist, I know anecdotally that some physicians will ask their patients to come off of hormone therapy if they're about to start a cancer treatment or if they're about to even have a particular surgery. I don't quite understand all of the nuances or reasons for those recommendations, but you can think about, a doctor is probably weighing in a lot of different pieces of the puzzle. But primarily what I talk about most is the risk of stroke and blood clotting disorders. That would be the number one probably reason why or if you have an existing cancer, then they might delay the decision making for hormone therapy to a later date. But yeah, that's my best answer. Oh, that just answered my question. Good. Yay. Next, I've been taking hormone therapy for 8 years and I am 60 this year. I was getting very confused and nervous. You helped a lot. Sounds like I should stay on it. Well, I'm not telling you to stay on it, but if I can help you or support you in any way in crafting the script that you want to take to the conversation, just to make sure that you know what questions to ask. I want you to be solid and confident in your decision making for whether or not you continue hormone therapy or you decide on a timeline with your doctor as to when you would want to stop it. And I want to address something about stopping or coming off of hormone therapy. Do not do it on your own. Do not do it cold turkey. Work with your prescriber and make sure, because you do not want to rock your world upside down again. And sometimes, any therapies, any type of medication or prescription therapy that we might be taking, often stopping cold turkey is not the way to go. So make sure you get some guidance and make sure that you continue with vaginal estrogen. I stopped in 6 weeks ago and I see. Sorry. I should have read all of your question before I started talking. Sounds like I should stay on it. I stopped 6 weeks ago and now I have hot flashes and night sweats again. Yeah. So the vasomotor symptoms are a check engine light. And it's really, really unfortunate that menopause and hot flashes and night sweats, i.e. vasomotor symptoms, have become sort of this social construct that when we look at any magazine, any media, any Google search for menopause, what we see is an image of vasomotor symptoms. Now, I think that has happened because vasomotor symptoms are one of the most visual images that menopause has. It's harder to put a picture on the internet or in the magazine of being tired, or harder to picture, bleeding for 45 days, or even vaginal atrophy, vaginal dryness. Really hard to picture those. So the media and marketers of the world have honed in on this image of vasomotor symptoms, but at the same time, they've also made vasomotor symptoms the punchline of a joke or the opportunity to minimize or patronize women's health experiences. And I'm saying it's time to stop that. Vasomotor symptoms are the equivalent of a check engine light on our car. What happens when the check engine light goes off in our car? We pull over, we lift the hood and we investigate. We find and treat the root cause. If you're still experiencing vasomotor symptoms, it means that your hormones are fluctuating or declining. It means that in the case of estrogen, when estrogen declines, it also means that our blood pressure and cholesterol might have increased. And estrogen is one of the protectors of our heart. So it doesn't mean you have heart disease, but it's an invitation for you to have your cholesterol checked, have your blood pressure checked. What if we use this opportunity, vasomotor symptoms, to prevent future heart disease by taking care of those cardiovascular markers now? Is the vaginal hormone treatment just estrogen, not progesterone? Can you expand on that? Great question. Yes. So for vaginal hormone therapy, for the treatment of vulva and vaginal dryness, and for the prevention of UTIs, but it also benefits the entire pelvic floor, the approved treatments include vaginal estrogen. So it's estriadol, and it is bioidentical estrogen. It comes in the form of, well, many application forms, a suppository, a cream, or there's even a ring that can be inserted. And in addition to estrogen, also approved in Canada in 2022 is DHEA. And DHEA is a hormone. And when it is applied to the vagina, and don't ask me how this happens, but DHEA breaks up into the amount of estrogen and testosterone that our body needs. And so that is also a very effective treatment for vulva and vaginal dryness. But it is not progesterone, although progesterone can be taken systemically and vaginally. So I do know some prescribers and some provinces in some cases that do prescribe progesterone, but progesterone is not for the treatment of vulva and vaginal dryness. I hope I didn't like totally confuse you on that, but I think I will add, just because a lot of prescribers and a lot of consumers use brand names. So if I could just even add in a couple of brand names to that answer, it sometimes helps with your conversation with your healthcare provider. So one of the more common brand, and I like not connected to these brand names in any way, I'm just trying to help in from a conversational standpoint. Vagifem is one of the most common forms of vaginal estrogen that is prescribed. Vagifem is a suppository, so the hormone therapy is encased in a wax coating and it's inserted. The dosage would have to be recommended by your doctor, but most of the women I know are using it 2 to 3 times a week. I hear lots of great results about Vagifem. One of the things I don't like about it is it ignores the vulva, and the vulva is the external part. What we're talking about when we talk about vulva and vaginal health is skin cells. And when we're treating skin dryness, we want to make sure that we take care of both the internal skin cells as well as the external skin cells. So a suppository or something that a form of hormone therapy that's inserted ignores the vulva. Estrogyn is another treatment, also an estrogen, but it's an estrone. And when it comes in a cream, and it's what I use. I like the cream. I like to apply it to my finger. I like to be able to insert it as well as take care of the vulva. So it's really going to be a personal thing. And to add even more information to this conversation, there is even a treatment that can be taken orally for vulva and vaginal dryness. My brain, I mean, that does some things for me. And I'm like, I can't comprehend taking an oral medication for the treatment of something with my vulva and vaginal health. However, I've spoken to many women about this, and Most of the treatments are recommended that you use at night, and many of us are so dog tired at the end of the day that we fall asleep and then we forget to take it, and then we're not sure if we should use it in the morning the next day or when we remember, and it throws everything off. And they're like, I just want something that I can take orally in the morning when I'm, awake, when I'm taking all of my other things, and so that's why there is an oral treatment available. Okay. Oh, does hormone therapy help with sex drive? Yeah, so changes to sexual desire are quite common as we navigate perimenopause to menopause to postmenopause. A lot of that can be attributed to hormones, and a lot of that can be attributed to stress. So one of the colleagues that I work with is Dr. Lori Brado. She heads up the sexual research lab here at the University of British Columbia, and all of her career research so far has been focused on sexual desire and the impact of stress, and the solution is the practice of mindfulness and meditation. And this is one of the reasons why when I talk about roles and responsibilities of our hormones when cycles are regular, I include cortisol, which is our stress hormone, just to make sure that we are not always blaming our sex hormones like estrogen and progesterone, um, because something else might be at the root cause. Having said that, tonight's class, we did not talk about testosterone to any degree. I do that in the master class. And testosterone is our hormone that's responsible for sexual desire. Testosterone therapy is not approved for women in North America, but it can be prescribed in an off-label format. I understand that that's complicated. So I would look at the research of Dr. Lori Brado. I would address stress. I would make sure that you're completing the stress cycle and addressing mindfulness and meditation as part of your overall health, including sexual desire. And if you can, have an investigative conversation with your healthcare provider about testosterone, and whether or not that would be something that would work for you. Everyone is going to be individual. To add to the previous person's question, if not, what else does? Yeah, so if you go to drloribrado.com, I believe she even has some free meditations on her site, but she's written 2 books on this topic called Better Sex Through Mindfulness, and it's evidence-based, and it's really good stuff, and it's been proven time and time again. So, okay. I'm on my husband's Zoom. Is vaginal estrogen available over the counter? The answer is no. I am not an advocate for any hormone therapy acquired over the counter, even though I know that progesterone is available over the counter in the United States. And there's probably many ways in which you can order progesterone online. Please do not take hormone therapy except under the guidance of a healthcare professional. That might be your family doctor, might be a nurse practitioner, might be a naturopath, might even be guided by another menopause expert, such as a pharmacist who might also be teaming up with a prescriber. But it's a very delicate protocol, and we have to make sure we're using the right hormones for our age and stage, prescribed at the right doses, and using the mode of delivery that is going to have the highest efficacy rate for me, because we want this to be successful and we want our body to respond and accomplish treat all of these symptoms that we might be having, but to also invest in our future health. So please do that. In terms of over the counter for vulva and vaginal health, I was a co-creator for a vulva and vaginal moisturizer. It's called Feel Amazing. It's available at moisturizeyourvagina.com. The reason that it's over the counter is that it is a moisturizer, so there are no hormones in it, but it includes hyaluronic acid. And hyaluronic acid is a naturally occurring molecule that our body used to make on its own, but it starts to decline in our 30s and in our 40s, and even more so at menopause. So, Dr. Petra Stute, who is a Swiss gynecologist, has done the research that showed that hyaluronic acid is effective for preventing and treating vulva and vaginal dryness. And one of the other reasons why I like and encourage women to use a moisturizer too is that you get to develop your own protocol. And remember what I was saying about vaginal hormone therapy treatments and how some of the modes of delivery ignore the vulva or ignore the outside. So you can take care of that. If you like Vagifem, if you like the suppository and it's working for you, then you can moisturize the vulva with the moisturizer. Whew, that was fun, you guys. I mean, it's not a fun topic. And I know we kind of veered off in a couple of different directions around conversations about hormone therapy, but they all match together. So the goal of tonight was to bring more awareness to the fact that we may experience breast tenderness, especially as hormones fluctuate in perimenopause, to shine a deeper light or a brighter light on the concept of how does hormone therapy relate to my breast health when I am making decisions, especially around the incidence rate versus assessing my own personal risk for breast cancer. And then the third part of tonight is to make everyone aware of dense breasts, what it means to us, what it means in terms of hormone therapy decisions and how we need to include that information into the shared decision-making process with our healthcare provider. And yeah, and then the Q&A. So I hope that it worked out for you. Thanks, Jen. And you can always find me at menopausechicks.com or the Menopause Chicks private community, which is menopausecommunity.com, or just type Menopause Chicks into Facebook. And I am happy to address your questions, or you'll learn about other educational opportunities there. And as PrimeCare Family Health has reminded me, we are working on a 5-part series for 2025. So hopefully you'll be back, and maybe even one day we can do this live in Milton. Thanks everybody for coming out. You're welcome.